From Microbe TV, this is Infectious Disease Puscast episode 42, recorded on November 22nd, 2023. Hello, I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. And I was going to say happy Thanksgiving, but I realize this is going to come out like right after.
It is. I guess we can wish happy Hanukkah and Christmas by the
Yeah.
time this drops.
Yeah. Happy holiday season where you say, I'm going to circle back with this in the new year.
Yes, so someone needs to go in and add all the holidays, make sure we're all inclusive.
Yeah.
Whatever you're celebrating, we wish you the best.
Winter holidays. Yeah.
Yeah.
Well, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So, on to the literature, shall we?
Well, we will start with viral. Remember to listen to This Week in Virology. And I'm going to start with the MMWR. I mentioned this also on my clinical update, which probably will drop before this, but Progress Toward Measles Elimination Worldwide 2020-22. Amid ongoing declines in measles vaccination, cases in 2022 rose by 18%, and deaths were up 43% globally compared to just the prior year. I just want to remind people these are children predominantly that are getting sick, that are dying.
For my first viral paper, I pulled from Transplant Infectious Disease, Slaying the Troll of Transplantation, New Frontiers in CMV Management, a report from the CMV International Symposium 2023. This publication summarized this recent meeting, which is mentioned in the title, which took place in Barcelona in May. It describes the many unmet needs in the management of CMV post-transplant, including understanding the indirect effects of CMV. How do we manage late onset viremia and other adverse events? I thought table 2 is really interesting. It's an illustration of different patient cases, and then they describe the conference delegates' preferences for prophylaxis versus preemptive therapy. So you can kind of see how people have different opinions on different scenarios. And I actually had kind of stumbled on this because I was refreshing myself on the literature for cell-mediated immunity testing for CMV and using these tools for management, which the hope would be that they can be used to guide or personalize decision making. So, for those who are sort of more uh, in this world in solid organ transplant, uh, cell mediated immunity has been most useful in differentiating risk in the recipient positive transplant patients. But it's sort of less established in the recipient negative serostatus patients, which are actually the ones you often are worrying about the most. And there isn't really a clear threshold separating low and high risk patients. And kind of lastly, we still aren't quite to an available vaccine. And as part of that, I think we don't totally know have the best understanding of the correlates of protective immunity in different clinical settings, and how do we evaluate the efficacy of those vaccines. So there are some candidates in development, which they describe in the paper, but just a really nice overview of sort of all the major topics in CMV and transplant.
Yeah, I would love a CMV vaccine. Just sort of thinking about that story of the tree you plant today, will provide shade for, your grandchildren. But
Yeah.
it'd be nice to live in a world where we didn't have to worry about a lot of these CMV complications.
Yeah.
All right. The article, Association Between Neutrophil-to-Lymphocyte Ratio and Adverse Outcomes in Children Aged Less than 2 years with Respiratory Syncytial Virus, recently published in JPIDS. So I don't know how many of our listeners remember discussions about using the neutrophil lymphocyte ratio to risk stratify COVID-19 patients. But here, these investigators looked at the association between NLR, neutrophil lymphocyte ratio, and adverse outcomes in children less than 2 years old with RSV. They found that in the 2,395 RSV positive children less than 2 years old. 18.6% had a CBC performed. So ultimately, we're going to look at 349. The median age was 3.7 months, pretty much evenly split, 51% male, 49% female, 77% hospitalized. Of those hospitalized, 68.8% received oxygen, 42% admitted to the ICU, 17% intubated. Right, so this is bad stuff. The odds ratio associated with a twofold difference in the neutrophil-lymphocyte ratio was significant for hospitalization. We see an odds ratio of 1.5. ICU admission, odds ratio of 1.4.
My next paper, which I think is a last viral one, is from CID, Pre-Exposure Prophylaxis Use History and People with Antiretroviral Resistance at HIV Diagnosis. Findings from New York City HIV Surveillance and Partner Services, 2015 to 2022. This study used, as mentioned in the title, surveillance and partner service data to measure the effect of a history of PrEP, so tenofovir with emtricitabine, on baseline prevalence of M184I or V mutations in people diagnosed with HIV, and found that PrEP use was strongly associated with a baseline M184 mutation in New York City, regardless of whether they were identified during an acute HIV infection. And so they categorize PrEP use as recent, so within the last 90 days, in the past use over 90 days before, or no known use. Of about 4,000 newly diagnosed people with who had a HIV genotype within 1 month of diagnosis, 13% had acute HIV infection, 3% reported recent, and then 35% reported past PrEP use, and 2% harbored an M184. And in people with acute HIV, recent PrEP use was associated with a 6 times greater risk of M184. And those without acute HIV, that risk in recent PrEP users was 8 times, and in the past users, 4 times as likely. And something that they noted is that fewer than half of all the newly diagnosed people in the study had a genotype done within 30 days of diagnosis. So this paper, obviously the benefits of PrEP outweigh the risks of acquired resistance, but I think, the authors really want to point out that there were missed opportunities for identifying undiagnosed infection and then obtaining genotype resistance testing for everyone with a new HIV diagnosis per guidelines.
Interesting. I'm thinking about the implications. Is this that, when we see M184 that breaks through, or are we selecting for the M184? And then I guess the implication of, what will be our best treatment for someone who gets HIV when they've been on PrEP. So
Yeah.
interesting stuff. All right, moving into bacterial, be sure to listen to This Week in Microbiology. And we have the article, Impact of 2019 FDA Guidance for Uncomplicated Urinary Tract Infection on Treatment Response Rates, a reanalysis of a clinical trial of nitrofurantoin versus fosfomycin, recently published in Open Form Infectious Disease. So they start by pointing out that the current FDA guidance recommends that the primary efficacy endpoint for uncomplicated urinary tract infection clinical trials be a composite of clinical and microbiological responses. Now, this is a slightly higher bar than just clinical resolution. So they do point out that going forward, we need to keep this in mind, and that this may limit the ability to compare antibiotic treatment effects between historical and future clinical trials. So person has to feel better, and you got to clear that urine.
Yeah. I pulled something on a topic that we don't see that commonly, but there are updated CDC guidelines for the prevention and treatment of anthrax 2023. So this is released in MMWR. I thought it was a good chance to review some stuff about anthrax. So this report specifically updated antibiotic and antitoxin use for post-exposure prophylaxis and treatment based on some systematic reviews of the literature. They really focused on expanding the list of alternative agents when first-line drugs are contraindicated or not tolerated. So as a quick refresher on anthrax, this is a zoonotic disease caused by Bacillus anthracis. Primarily affects sheep, goats, cattle, and then humans are secondarily infected with or affected with a clinical syndrome related to the route of inoculation. So, cutaneous anthrax is direct inoculation of spores through the skin, which is over 95% of the cases. Ingestion anthrax, so consuming infected meat. Inhalational, which is inhaling aerosolized spores. Injection anthrax, so for example, an injection of heroin that's been contaminated with spores. And then meningitis can complicate any form or occur alone. And there are three primary virulence factors. There is an extracellular capsule, two exotoxins, and an edema toxin. So I actually didn't know the number of cases. There's been 9 US cases since 2006 that have been reported. And of course, there's way more detail than this, but just for highlights, for post exposure prophylaxis and treatment regimens for cutaneous anthrax without meningitis in non pregnant adults, the recommendation is a single antimicrobial drug. So, first line is doxycycline, ciprofloxacin, or levofloxacin, or if you happen to have susceptibilities back and it's penicillin susceptible, you can use amox or penicillin. If no drugs are available, then patients can receive a single anthrax antitoxin. And so if there is systemic disease and or meningitis, the preferred treatment is two bactericidal drugs from different classes, a protein synthesis inhibitor or an RNA synthesis inhibitor. So an example would be Cipro plus Miro plus minocycline. So there's some separation there for the pediatric guidelines, but really, like, they all are essentially referring to the same list. Um, and then, not surprisingly, there's kind of no data in neonates and premature infants. But a nice review, and there's a great table if people need to refer to it.
All right. The article Contemporary Use of Cefazolin for MSSA Infective Endocarditis Analysis of a National Prospective Cohort, recently published in the International Journal of Infectious Diseases. So we read the aim of this study was to assess the real use of cefazolin for methicillin susceptible Staph auris infective endocarditis in the Spanish National Endocarditis Database games and to compare it. What do you think of that? Games and to compare it
Where's the
with,
G from? I
yeah,
guess
where
I
did
have
they
to
get
look
that
up the
G?
acronym.
Got that from? You know,
It's
it's
probably in Spanish.
probably in Spanish, yeah. So outcomes assessed were relapse, intra-hospital, overall, and endocarditis-related mortality and adverse events. Risk of renal toxicity with each treatment was evaluated. So the study ends up including 631 infective endocarditis episode caused by MSSA treated with cloxacillin and or cefazolin. What do we see? So patients treated with cloxacillin presented higher rates of septic shock, and new onset or worsening renal failure with significantly higher rates of in hospital mortality. 1 year infective endocarditis related mortality and rate of relapses were similar between treatment groups. And in their highlights, we read cefazolin might be considered first line treatment for MSSA endocarditis. And dare I go ahead and agree?
Yeah, yeah. Agreed. In CID, is carbapenem therapy necessary for treatment of non-CTXM ESBL producing Enterobacteriales bloodstream infections? So we don't really know whether antibiotics should differ based on ESBL enzyme family that is produced. The author's findings in this paper suggest that non CTXM and CTXM ESBL producing Enterobacteriales is such a mouthful. Bloodstream infections are equally concerning and associated with similar outcomes, and that meropenem may be associated with improved survival in patients with non CTXM ESBL Enterobacteriales bloodstream infections. This was a multi-center observational study looking at 500 patients with ceftriaxone-resistant Enterobacteriales bloodstream infection from 2018 to 2022. Broth microdilution and whole genome sequencing confirmed susceptibility and ESBL gene presence. 79% were confirmed to have ESBL, and the odds of 30-day mortality or recurrent ESBL Enterobacteriales infection was similar between the non-CTXM and CTXM group. So odds ratio 0.99, confidence interval 0.87 to 1.11 with a p-value of 0.83, and then odds ratio 1.10, confidence interval 0.85 to 1.42, p-value of 0.047. So when looking at the non-CTXM group, meropenem treatment was protective against mortality compared to piperacillin tazobactam. 86% of 21 patients were alive on day 30. None of the 5 patients on pip-tazo were alive on day 30. So again, suggesting that pip-tazo may not be the preferred treatment for patients with non-CTXM, ESBL, Enterbacterialis infections. One extra nugget that I will just include is that none of the 5 patients infected with the non-CTXM, ESBL, treated with cefepime died within 30 days. But despite this, the authors would still be cautious using this based on prior data. And that's really what has informed the IDSA AMR guidance.
Okay. I mean, it's
So
interesting,
mirror.
Sarah. I guess, well, I still remember the trial when it was like, oh, you've got to use carbapenems every time there's an ESBL. And then they sort of looked and were like, well, yeah, you certainly can't use Zosyn when it's resistant to Zosyn because there were issues in that study. So it just seems like it gets more or less complicated every day.
Yeah, clear as mud.
Exactly. All right. And so the article, Infectious Disease Consultation Associated with Reduced Mortality in Gram-Negative Bacteremia, was published in CID. And here we see that, yes, in this 24-site observational cohort study of unique hospitalized patients with 4,861 gram-negative bloodstream infection episodes demonstrated, are you ready for this? A 40% decreased risk of 30-day mortality in patients when compared to those folks not getting the ID consultation. What are they doing when they don't call us, Sarah? What's going on?
Yeah.
It's like Schrodinger's cat. Like, I don't know, because if they call me, then I know.
Yeah. Yeah.
All right. Well, I will move on to the article, Contemporary Management of Staphylococcus aureus Bacteremia, Controversies in Clinical Practice, recently published in CID. And I actually like this. It's just a reminder, I think, to be thorough, right? And so they talk about the evaluation, get that thorough infectious disease history, get that thorough physical exam where you're looking for, intravenous catheters, where you're palpating the spine. Call the ID doc, have them do all that. They've got that right in the front because patients do better when we get called. I talk about echocardiograms, really a nice infographic that really walks you through all the things to be thinking about. Address potentially drainable foci. Apparently, ChatGPT forgets about source control, so that's why call us instead of the AI. But really, I will recommend spending a little time on this article.
Yeah, it's really nice. And it's nice they actually, even in the graphic, have a section for comorbid substance use disorder, like directly in a Staph aureus bacteremia paper, which I think is awesome. Well, I will take us into our fungal section. This one I thought was so cool. I don't normally mention papers from Nature, but I did for this time. So, published in Nature, tuning sterol extraction kinetics yields a renal sparing polyene antifungal. So, amphotericin B is an antifungal that we all know, maybe don't always love, but belonging to the polyene macrolide group of antibiotics. It is known for its nephrotoxicity, earning it the name amphotericin. It was thought that amphotericin B killed fungi by forming ion channels to increase the permeability of the fungal cell membrane. But it seems that ampho actually mainly kills fungi by forming these large sponge-like aggregates that remove ergosterol, a compound similar to cholesterol that's abundant in the cell membrane of fungi. So removing that ergosterol from the cell membrane of the fungus. And I have to say, I just took my PEDS ID boards, and there definitely was an amphotericin mechanism question. And I don't remember my answer,
Did,
but I
did they
somehow
get
think
did
it,
they get it right?
yeah, I somehow don't think that sponge like aggregate was one of the options. So this study used biophysical and synthetic methods to probe uh, whether a mechanism, so removing a crucial cell membrane component, drives the renal toxicity, with the hope that it can provide a way to sort of mitigate this. So they synthesize analogs of amphotericin B that allowed them to vary particular structural sites that affect the biologic activity. And they linked renal toxicity in human kidney cells and mice to binding of amphotericin B to cholesterol in the kidney cell membranes. They also created some high resolution structures of ampho with and without sterile molecules, and comparative analysis revealed the stabilizing interactions in the ampho B and a sterile sponge aggregate. So all of this was suggesting that if we just tweak the structure of amphotericin B, that maybe it would eliminate its ability to bind cholesterol, which causes renal dysfunction, but preserve its capacity to bind the ergosterol, which would lead to a renal sparing antifungal. So the new Ampho B form was less potent due to a reduced rate of ergosterol removal. So they did another modification, and ta-da, made AM-2-19, maybe there's a snappier name, a quote, first of its kind renal sparing polyene macrolide with potent broad spectrum fungicidal activity and evades the development of antimicrobial resistance. So, hopefully I interpreted all of this study correctly, and was trying to do my best to summarize it, but I'll say it another way. So we thought ampho led to membrane permeability, but actually it kills fungi by forming these extramembranous sponges that extract ergosterol from the lipid bilayers of the fungus. And separately, cholesterol extraction drove the toxicity of ampho in human kidney cells. So if they make some selective changes to the structure related to what kills the fungus, but not our kidney cells, led to a new amphotericin. So really cool. Hoping to hear that it does well in clinical trials.
I'm just thinking, like, the next time I take the boards, I'm allowed to raise my hand and say, I don't think you've been keeping up with the literature. That's
Oh, yeah.
all right. Well, this is a very exciting article. Impact of in-house Candida auris PCR screening on admission on the incidence rates of surveillance and blood cultures with C. auris and associated cost savings, published in Open Form Infectious Disease. So, in this study, patients were tested based on risk factors for C. auris carriage. Pre-intervention, the PCR was sent out to a reference lab, and you're going to find out long time later you'd get the results. Post-intervention was performed in-house. Changes in the incidence rate of C. auris present on admission and C. auris hospital onset fungemia were assessed using this time series analysis. The economic impact on isolation and testing costs were calculated. Is it cheaper to do it homemade or send it out? Post-intervention, the IR of CAPOA, C Candida auris present on admission. Now, why did they do that with three-letter acronyms? In plain English, oh my. The incidence rates of Candida auris present on admission compared to the pre-intervention rates, 2.57. So basically, they were missing most of the Candida auris on admission doing that send out, and using an in-house test, they caught more than twice as many, but perhaps so simple as the amount of Candida auris is increasing each month. And as we read, the baseline rate of Candida auris hospital onset fungemia, they've got a great acronym for that, was increasing monthly by 14% pre-intervention, while during the post-intervention group, there was a change in slope with a monthly decrease of 13%. So it turns out a big thing is also timely return of results. When they sent it out, the turnaround time was reduced from 11 days to 2 days. Savings were estimated between 772,000 to 3.7 million. And I just like to point out each time, like, because we're talking about Candida auris, at one of the hospitals where we work, we have a Candida auris aficionado, Michelle Cho. So just remember, if you've got that Candida auris consult, no need to call me, call Michelle Cho. We actually were talking about this today, and so she'll be entertained. She is not a Candida auris aficionado, by the way. Full disclosure. All right, let's move on to human Lobo micosis, caused by Paracoccidioides, Lacazia loboi, Panama 2022, published in Emerging Infectious Diseases. So, a little background is warranted. Lobo micosis, also known as lacasiosis, is believed to be an uncommon chronic fungal infection primarily affecting the skin and subcutaneous tissues. It was identified in the mid 1930s and is caused by the dimorphic fungi Paracoccidioides, Lacasia, or loboi. So, clinically, this manifests as a slow growing infection, these nodular lesions that can lead to disfigurement and functional impairment if left untreated. So here's a case of an 87-year-old woman from Capira in western Panama, referred to a hospital in September 2022 to rule out the other skin lesion down there, leishmaniasis. Her condition began 40 years earlier. Oh my gosh. Talk about delayed diagnosis. Started with a hyperpigmented nodular lesion on the left leg, progressed to multiple non-fluctuant, indurated, and exophytic nodular lesions throughout the affected limb, later involved the scalp. While initially painless, her lesions did not interfere with daily farming activities, but went on to develop occasional pain, ulceration, discharge, swelling, no penetrating trauma. They finally do a biopsy 3 years earlier, which they interpreted as sporotrichosis, treated with itraconazole and cryotherapy, not helping so much. Electron microscopy showed this multiple tissue-bound yeast forms, ultimately identified P. loboi by nanopore sequencing. Ends up getting treatment, slow and minor regression of the nodules. And as I will be headed to work in Panama on the Costa Rican border next month, I will mention that this is where most of the cases so far have been identified. There are some pretty interesting photos that people should take a look at. All right, moving into parasitic. Be sure to listen to This Week in Parasitism. And if our listeners also listen to that, but we are upping our game to every 2 weeks, so not quite this week. The article, Molecular Surveillance Detects High Prevalence of the Neglected Parasite Mancinella ozardi in the Colombian Amazon, published in JID. So for starters, this is an insect-transmitted filarial parasite. 3 species of insect-transmitted parasitic nematodes, Mancinelli ozardi, Mancinelli persistans, and Mancinelli streptocerci, are responsible for the majority of human cases, although there are some other Mancinella species with potential to infect humans. Now, the current gold standard for the diagnosis is blood smear looking for the circulating microfilarial stage. Blood smear microscopy identified microfilaria in 12.7% of the sampled individuals. Pretty much what we've been seeing historically. But then you have all these other people thinking that they also might have some parasites. And you might believe them because they're living in the Amazon. So here they do this molecular testing, whole blood lamp assays. 40% of the folks sampled actually were positive. So agreeing with recent PCR-based surveys in the Amazon region and neighboring countries. All right. Well, thanks to COVID-19, everyone is now familiar with ivermectin. But what is it good for? That makes me think of the song by Edwin Starr, but ivermectin, unlike war, has its uses. The article, Efficacy and Safety of Moxidectin Compared with Ivermectin Against Strongyloides stercoralis Infection in Adults in Laos and Cambodia, a randomized, double-blind, non-inferiority phase 2b/3 trial, was published in the Lancet Infectious Disease. And here they compare the good old horse dewormer ivermectin with weight-based dosing and moxidectin at an 8 milligram one-dose-fits-all alternative macrocyclic lactone. I knew that biochemistry would come in handy. Macrocyclic lactones act as GABA agonists and also bind to glutamate-gated chloride channels in nerve and muscle cells of invertebrates, making them excellent broad-spectrum antiparasitic and anti-arthropod drugs. Both drugs, given as a single dose, had excellent efficacy. And other than some abdominal pain and some headaches reported, and an uncontrollable urge to start podcasting or getting on AM radio for the ivermectin arm people did very well with relatively equivalent high level of efficacy. They conclude by saying the fixed dose and lower cost of moxidectin compared with ivermectin make an valuable alternative for people with strongyloidiasis.
Nice. And
And we got
then I think I'm finishing us out with the miscellaneous. Three very different articles. The first one is from CID, efficacy of bortezomib for treating anti-interferon gamma autoantibody-associated adult onset immunodeficiency syndrome. This is a clinical entity that I find so fascinating, so I had to grab it. For some background, there have been increasing reports of adult onset immunodeficiency syndrome that is caused by anti interferon gamma autoantibodies. It has predominantly been reported in Asia, but has been present in other locations. And so these patients are at risk for opportunistic infections, particularly with non-tuberculous mycobacteria, but also other intracellular pathogens. So salmonella, BZV, crypto, histo, and also Tayloromyces, which is relevant, particularly for the patients who are living in Asia where that may be endemic. So there is no approved medication to reduce the autoantibody level in patients. But rituximab and cyclophosphamide have been utilized with some clinical response and improvement in outcomes. Bortezomib is a proteasome inhibitor that efficiently reduces both short lived and long lived plasma cells. So you may more often have heard of this used for refractory multiple myeloma as well as some other autoimmune conditions. But the authors here were seeking to understand whether bortezomib would decrease those autoantibody levels in these patients. So this study specifically is from Thailand, where eligible patients were the typical patient. They were 21 years old or older, HIV negative, had evidence of the positive autoantibodies, and a history of prior opportunistic infection. They received once weekly bortezomib subcutaneously for 8 weeks, followed by oral cyclophosphamide. This showed no significant decrease in antibody titers, and 10 opportunistic infections were identified, and the patients included during the 24 to 72 weeks of bortezomib, suggesting that we probably still need the rituximab component. But just another interesting insight into this clinical syndrome. And then from Transplant Infectious Diseases, I pulled a paper, Investigational Non-Antibiotic Therapeutics for Infections and Sorry, I don't know why I'm so
hematopoietic.
hematopoietic
You got it.
stem cell transplant recipients and patients with hematologic malignancies receiving cellular therapies. I just thought this was a really cool and great summary of some of the non antimicrobial treatment options for infections that come up a lot, particularly if you are working in this immunocompromised ID space. So, for fungal infections, they talk about immune checkpoint inhibitors, granulocyte infusions, and colony stimulating factors. For bacterial, they note bacteriophage therapy and FMT. And then for viruses, a little background into the evidence for allogeneic virus specific T cells. So it's a pretty quick read, but gives a overview of a pretty complicated topic. All right. My last one, because I feel like we're just going to have an AI piece in each episode now. This one was also from CID, Black Box Warning, Large Language Models and the Future of Infectious Diseases Consultations. So, this was a discussion on the use of large language models and their promotion as clinical decision aids. The authors spoke to the limitations that can occur, such as confabulation of clinical data and or references, inscrutable training data and methods, lack of contextual awareness crucial for nuanced clinical decision making. So, like you mentioned, shouldn't we have source control? Propensity to recapitulate medical biases in training data. And so, to finish this out, I actually just pulled a quote from it. LLM, so large language models, technology is rapidly advancing, but unlike ID specialist consultation, is unproven to benefit patient outcomes. ID clinicians must advocate for clear boundaries and regulation of how LLMs can be used to safely augment cognitive specialist care. So, we will continue to bring you papers on the benefit of ID consultation as well as whatever new AI things are coming out. So, that's all I got. That brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts and microbe.tv/Puscast. We'd love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. And if you like what we do, consider supporting the science shows at Microbe TV at microbe.tv/contribute or Parasites Without Borders at parasiteswithoutborders.com and click on the donate button.
I'm Sarah Dong. You can find me online at swindong, at Febrile Podcast, or at febrilepodcast.com.
And I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.